So DIC, do you guys all know what DIC is? We kind of like, for a second, talked about it when we talked about blood, right?
And then OB.
And OB, you guys got it in OB too? Anybody see a patient in DIC in any of the time they've been at the hospital? You may have if you were in the ICU and just not even known it, because it's not how you picture, like you picture DIC as like someone hemorrhaging, right? Out of every orifice. Isn't that how we all picture DIC in nursing school? It doesn't always look like that. So, what is DIC? Disseminated means widespread, right? Intravascular coagulation. So there's widespread bleeding, but there's also widespread clotting, and it can be either or both. It doesn't have to, you don't necessarily have someone hemorrhaging. So there's a spreading or dispersing of coagulation in the microvascular system, in the microvasculature of every system. So is DIC a disease?
No.
No. What is it? Yeah, so it has to do with an underlying issue. DIC is not a disease. The patient doesn't just get DIC just out of the blue. There's always an underlying issue that's going to cause the DIC. It's a secondary, not disease, because it's not a disease. It's a secondary condition. Secondary to a disease, yes. Always secondary to some underlying condition. So it can be acute, subacute, or chronic. So what do you think are some things that would cause acute DIC? So your patient was healthy and suddenly they have this system going on where they're sending out clots and they're bleeding. Infection, so sepsis, shock. Someone said OB earlier, right? So it could be that they went into like that HELP syndrome. They're preeclamptic. Cancer, so some malignancies will cause acute. What about subacute?
The OB you talked about.
Yeah, it could also be OB. So sometimes if you have like the retained fetal tissues or certain cancers, METs will be a subacute. And then chronic would be like your liver disease, certain types of malignancies, and lupus. So what do you think chronic DIC looks like?
Deterioration over a long period of time. Like you said, it was liver disease, something that.
So what does your body do though, like when things happen? Does it compensate? So do you think a chronic DIC is going to look the same as an acute DIC? No, because it's something that's come on slowly and your body has kind of compensated along with it. So it might just be that their labs are off and maybe they're a little anemic or something's going on, but they're not going to look like your acute DIC patient, right? What's that? Acute is definitely more severe, yes. So I'm going to pause the recording and show you guys a short video. Okay, so you guys have access to that video if you wanted to rewatch it. I used to stand up here and try and explain the whole thing, and then I found that video and I was like, genius. Like, being a visual person myself, I always think it helps to be able to see it. So, anybody have any questions about that? No. Okay, so basically your body is making the clots and trying to break them down at the same time. That's what DIC is, right? So it's throwing out all the platelets and coagulation enzymes, but at the same time it's throwing out the enzymes to break them down so that the clots don't get too big, and it's just fighting itself. So that's essentially all DIC is. we can have bleeding manifestations. So tell me what the bleeding manifestations are going to look like in your patient. What are you going to be watching for?
Shock.
Bleeding, but from where? Like, what do you?
For the things
It can be so you can get.
IVs.
What is it going to look like if they're bleeding under the skin? What do we call that? Petechiae. So petechiae is never good, right? Like, you should never just have petechiae. It's usually something going on if you have some sort of petechiae, right? So DIC, petechiae is one of the things that you might see, especially in somebody in like the ICU. They have the big distended abdomen, and then all of a sudden they have petechiae. Oh, that's never good. Brushing their teeth, suddenly they say, I don't know, my gums just suddenly started bleeding today. Or someone young who's in the hospital and maybe after they just delivered a baby and suddenly like they're just bruising super easily, right? They came in to take blood and now like they have this huge ecchymotic area. Or the case study we're going to do, the woman has a big bruise from where the blood pressure cuff was, and so the nurse questions it and she says, oh, it's just from the blood pressure cuff. That's not normal, right? So some of the bleeding manifestations might just be that you see them bleeding from the gums, petechiae, maybe their IV site or PICC line sites are bleeding, nosebleeds. What about thrombotic manifestations? What's that going to look like? It could be cyanosis.
Cyanosis,
It
ischemia,
could be tachypnea
Gangrene.
if it's like a PE or something, yeah.
gangrene.
Gangrene. So basically like the tips of the fingers, the tips of the nose, you're going to find that they're all turning like cyanotic and then eventually necrotic, right? Because the little baby clots are getting into that microvasculature. So those are the things you can see, but what about the things you can't see? So like all the little capillaries in the lungs, right? Capillaries in the kidneys. So this is when we start talking about your patient is in ARDS next week. We start talking about how the capillaries are full of stuff so the oxygen can't get through. This is one reason it might happen. So maybe the kidneys are not being perfused because of the clots. So what would be going on with your patient?
Kidney failure, not taking the medication.
They're not urinating, oliguria, right?
Toxicity.
Good. So when we talk about the diagnostic studies, and I know that he just talked about them in the video, but I'm going to give them to you again, and I want you to write them down because you need to know these. So tell me what your PT is for thrombin time. So PT and PTT, I always just think of them as bleeding times, right? So I always think if my PT or PTT is high, it means my bleeding time is longer. So that would be bad, right? So in these patients, you'll see increased PT and PTT. That's how I think of it. What about FSPs and FDPs? What did he say those were?
Fiber split products.
Right, so fibrin split products or fibrin degradation products. What is that?
That means it's clotting too much, like it's overloading, right?
The clot is eaten away and it gets freed, and that's
Right, so yes, it's clotting too much, so the body's sending out stuff to stop the clotting, and it's basically the pieces, the products of the breakdown of the clot.
So then it would be elevated.
So they would be elevated. Your D-dimer, which is a specific fibrin degradation product, would be positive. Sometimes you'll see actual numbers for the D-dimer, and you don't have to know the numbers. And honestly, for the test, you don't need to know the numbers for any of these. You should have some sort of idea, like general idea, what like your PT and PTT are, and your platelets and your fibrinogen. But we're not going to give you numbers. We said the D-dimer would be positive. What about the platelets? Low. Why? Because they're using them all up trying to clot everything, right? What about the fibrinogen? Low. Same reason. Using up all those clotting factors. So basically everything is going to be elevated except for the platelets and the fibrinogen are going to be decreased. some nursing diagnoses that you might think of for these patients? Risk for bleeding, definitely.
Give them fluids and then frozen blood or something.
No, the nursing diagnoses, not the care. Risk
Organ
for
failure.
circulatory impairment. So
Organ failure.
I just heard ineffective tissue perfusion. So yeah, in the book, the ones that the book give you is the ineffective tissue perfusion related to bleeding. Acute pain related to bleeding into the tissues and diagnostic procedures. Decreased cardiac output because you're going to have fluid volume deficit. And anxiety related to the unknown, the disease process, fear of dying, like you name it. But those are the ones listed in the book. So what are we going to do for these guys? Yeah, basically that's the big thing, is treating the underlying cause. So we're going to stabilize them. What? You could give them platelets. So we're basically going to do supportive care, right? So whatever's going on with your patient is what you're going to treat. So if they're bleeding, we're going to look at their hemoglobin and we're going to say, do they need red blood cells? We're going to look at the other numbers and say, what about their platelets? Do they need platelets? Do you remember what the fresh frozen plasma does? Oh, you guys brain dumped that. Test one's done, Miss Mistretta. Yeah, so the FFP are clotting factors where the platelets are just platelets. But yes, so the FFP has the clotting factor. So, I mean, and some of these patients, if they are in the hemorrhaging DIC, they might be getting a little bit of everything thrown up there, right? So we might be giving them platelets and FFPs and red blood cells. So we need to treat the cause, which means we need to figure out the cause, because your patient might walk in and have stuff going on and, you know, you won't immediately know what's going on with them, right? So you have to do a little digging and all of your assessments. We need early detection so that we can get in there and stop the bleeding or whatever's going on. Stop the clots from growing. What do you think we do for the clotting part of it? What kind of blood thinners? Heparin, right? And you're thinking, how are we giving them heparin? Because they might be hemorrhaging at the same time. It's true, they might be, right? So we might be hanging stuff up and giving them platelets and everything else, but we might be giving them heparin at the same time. So your goal is to keep your patient alive, right? We want to make sure that we're maintaining perfusion of the organs. So that's going to be our big thing with these patients. Until we can treat that underlying cause, we want to make sure that we are at least monitoring the perfusion. So how are we going to monitor the perfusion of the brain? Level of consciousness, alert and oriented, right? What about the heart? Respiratory rate. Make sure they don't have any chest pain. Pulses. Lungs. Lung sounds that they're breathing, right? Kidneys, that they're producing urine. Good. So, I mean, that is DIC in a nutshell. So, what we're going to do